Okay, it is now 12 o'clock and we can get started. Um, Hello, everyone. Thank you for joining us. My name is Kitty Jewell, and I work at the SIU Center for Rural Health and Social Service Development in Carbondale, Illinois. This webinar series is funded by the Illinois Department of Human Services Division of Substance Use Prevention and Recovery through a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. Today's webinar is entitled Best Practices, Barriers, and Facilitators to Buprenorphine-Naloxone Prescribing in Rural Communities. It's presented by Dr. Chandra Spate. Dr. Spate is an assistant professor in the Department of Advanced Nursing Practice and Education in the College of Nursing at East Carolina University. In 2020, she completed her doctoral dissertation titled Barriers and Facilitators to Buprenorphine Prescribing Among Nurse Practitioners Working in Primary Care Settings in Eastern North Carolina. Her research focuses on overlapping topics of nurse practitioner clinical competence and capacity, healthcare access in rural areas, and healthcare policy. And she has been published in Nursing Forum and the Journal of the American Association of Nurse Practitioners. She has shared her scholarly work at the Southern Nursing Research Society Annual Conference, the North Carolina Nurses Association Nurse Practitioner Spring Symposium, the American Nurses Association Quality Conference, and the National Council of State Boards of Nursing Scientific Symposium. Dr. Spate holds a Master's of Art in Political Science, a Master's of Science in Nursing, and a PhD in Nursing. In addition to teaching healthcare policy, translational science, and clinical courses to advanced practice nursing students, Dr. Spate works as a family nurse practitioner at a health department in rural Eastern North Carolina. So following this webinar, you will receive an email with a link to a short evaluation. You will need to complete the evaluation to claim your credit. This link will be active for 30 days, after which time it will disappear and you will no longer be able to claim your continuing education credits. So now I would like to welcome Dr. Spate.
Thank you. I am going to share my screen. And just give me a second. Okay, do you see my first slide now?
Yes, it's perfect.
Hello?
Yeah, we can, we could see your screen. Now we see the,
You could. Okay,
notes.
I just didn't hear anyone say, so
Sorry.
I got nervous. Okay, that's okay.
Sorry.
All right, so now we're good. So thank you for that wonderful introduction, and thank you for having me here today. Again, I'm Chandra Spate, and I'm going to talk to you about barriers, facilitators, and best practices for buprenorphine-naloxone prescribing in rural communities today. You may be disappointed with the best practice section because it's just not possible to cover all best practices in this short amount of time, but I will point you to some resources and hopefully give you a few tips. I want to just draw your attention quickly to the photograph here on the left, and I'll come back to it in another one in a few minutes, but this is a photograph advertising for Suboxone treatment that I took about 20 miles from my house at what is, believe it or not, a major highway where I live, or maybe you do believe it because apparently you all are in a fairly rural region. But when we say major highway, that means 2 lanes and a little bit more of a shoulder than a country road. But anyway, this image really captures some of the treatment access problems in our community. So a quick overview. Really an outline. Today we're going to talk a little bit about background and context of the opioid crisis and disparities, harm reduction and medications for opioid use disorder, some legislation and regulation surrounding prescribing medications for opioid use disorder, treatment barriers and facilitators, and then I'm going to talk to you about my tips and toolbox. So I got such a great introduction, but I want to talk to you a little bit more about who I am and what I do so that you have some context. I am a nurse practitioner, I have a PhD in nursing, and I'm faculty in the College of Nursing at East Carolina University. And our mission is to serve as a national model for transforming the health of rural underserved regions through excellence in innovation in nursing education, leadership, research, scholarship, and practice. And so as part of that mission, I and the other nurse practitioner faculty at East Carolina University practice in rural areas. I practice in a rural North Carolina health department. And my research focus, consistent with our mission, is on access to care in rural areas. And I've really honed in on substance use disorder care access because the opioid crisis has so profoundly affected my region that I live in. I'm also right now the primary investigator on a SAMHSA grant where we are educating all of our nurse practitioner students in substance use disorder treatment. And we're really excited about the work that we're doing. And this semester, for the first time, all of our nurse practitioner students who graduate will have had specific education in screening for and treating opioid use disorder. And they will all be ready to apply for DEA-X waivers. So we're excited about that. We saw a need in our community. And again, consistent with our mission, we're trying to address problems to access for opioid use disorder. So a little bit about where I live. The reason I want to talk about this is because context when we discuss substance use disorders and opioid use disorders is so important. And when I was asked to do this talk, which was back in the fall, I started researching where you live, and with the idea of providing statistics about what your area looks like and what health disparities your citizens face, what healthcare looks like there. And it fortunately dawned on me how ridiculous that is. You know where you live, you know what your citizens are like, what they lack, what the strengths of your community are. Let me tell you a little bit about where I live and what my community is like so that you can understand the lessons I've learned in that context. So a lot of people think of North Carolina and they remember that we're bookended by the mountains and the beach. And this is a FedEx truck driving up to my house, of course. So you might hear a little noise. But this picture on the left is Hickory Nut Falls, which is where Last of the Mohicans was filmed. And I took that picture a couple of weeks ago. I was at a nursing conference that was fortunately in the mountains. And then you also might think of our beaches because those are also featured in a lot of films. Nicholas Sparks is from the town where I live, New Bern, North Carolina, and his books are set a lot on the beach. But really where I live, Eastern North Carolina, is a very, very rural agricultural community. I am from tobacco farming families on both sides. Most people from around here, as we would say, are. You probably pick up on my Southern accent. People around here don't think I have much of an accent, but I'm sure to you all, I sound, or y'all, as we would say, I sound like I do. But most we don't have a lot of industry. We're tobacco farmers, soybean farmers, corn farmers, hog farmers. Much of our industry is still sort of farming based, like pulp and paper. We have a Bosch factory, and then we have a lot of military in the area, several large military bases near us. So that's kind of what my community looks like. North Carolina experiences some pretty profound health disparities. We are not doing well compared to national averages on most health indicators. So this first on the left, obviously, is a map of all of North Carolina. And then on the right is a map that I created that pulls out Eastern North Carolina. So Eastern North Carolina, where I live, teach, and practice, is a 41 county area. It's a large area. It's about the size of New Jersey, and New Jersey is a pretty big state. But despite the fact that we're about the size of New Jersey, only about 3 million people live in our region, so we're pretty sparsely populated. We actually, in North Carolina as a whole, not Eastern North Carolina, we have the second most, let me figure out how to say this the right way, it sounds confusing. We're second only to Texas in terms of our rural population. So we're very rural. There are 2 major urban areas, the Durham-Raleigh area and then the Charlotte area, but mostly we're a rural state. As a whole, North Carolina ranks 34th in premature mortality nationally, but if we took only the counties of Eastern North Carolina, we would rank 43rd, so 7th to last in terms of premature mortality. Basically, every patient I take care of has hypertension, diabetes, and coronary artery disease, the trifecta. It's rare not to care for a patient that has those 3 disease processes going on. Also, a lot of obesity and still a lot of smoking in our area because, like I said, we are a tobacco region. Infant mortality, which is often seen as a reflection of a community's health as a whole, is unfortunately incredibly high in my region. In Bertie County, which if you can see my cursor is right up here, the infant mortality rate there actually exceeds that of El Salvador and Vietnam. So we're not doing very well in terms of access to care for pregnant women. 75% of the counties in this region are in the lowest tier nationally for overall health outcomes. It won't be a surprise for you to hear that we haven't expanded access to Medicaid in our state. We haven't signed on, and we're hoping that in this legislative session we might see some changes there. So getting to the opioid crisis, I just wanted to set the context of this state so that I could lead into what the opioid crisis looks like in our state. So as you may know, the South is home to more individuals experiencing opioid use disorder than any other region in the nation, and we're in the South. And my state of North Carolina has been particularly hard hit. Unfortunately, we had the notoriety a few years ago when there was this study of the top 25 cities for opioid use in the United States. The top 25, 4 of them were in North Carolina. So 4 of the top 25 cities were in the state of North Carolina. And then 2 of those cities were in Eastern North Carolina, the region where I live. And one of those cities was Wilmington, which you may have heard of for the film industry, but that was the top city in the nation for opioid use. We have made some strides in North Carolina to try to get a handle on the opioid crisis, but like other states in our nation, we haven't seen a lot of success in this point, and in fact, our overdose rates are going up. We still have a pretty profound overprescribing problem in North Carolina, and particularly in Eastern North Carolina. And one of our in one of our counties 2 years ago, we had 168 opioid prescriptions per 100 residents in a very rural area. Overdose death rates nationally are 45% higher in rural than in urban areas. And we see those same statistics in North Carolina and in Eastern North Carolina, that we're about at a 50% higher rate of overdose deaths in our rural areas than in our urban areas. About 7 North Carolinians die each day right now from opioid overdoses. We've seen a 900% increase in neonatal abstinence syndrome since the early 2000s. And about 50% of the children who are in foster care in North Carolina have a parent with opioid use disorder. So you're wondering, why is she here? Her state's doing so poorly. We're not doing really well in Eastern North Carolina. And this brings me back to those pictures that I showed you. Here's another one. Again, this is outside of a small community near where I live. It's a very rural community. It's been very hard hit by the opioid crisis. And I started noticing as I was driving around, this is the intersection of Highway 17 and Highway 43. This is a major thoroughfare to the beach. Signs for Suboxone, just in the middle of nowhere on the side of the road, signs advertising Suboxone. And that was so powerful to me as to where our community was and how little help we had. And you wouldn't know if you weren't from North Carolina, but 704 is a Charlotte area code. This was a telehealth company out of Charlotte that was coming into this community to try to get business for Suboxone's prescribing. But what's so, if it weren't so tragic, maybe laughable about these images is this is a region that has very poor internet access. There is not access to broadband in most of the areas where we live. And even those areas that have it, a lot of people can't afford it. So this program didn't go very well because telehealth just has not been the silver bullet in terms of access for our region because of some of these internet issues. It's broadband, as they say, is the Achilles heel of telehealth for rural communities. So as I think I've made the point, opioid use disorder is a public health crisis. You know that. It's impacted my region very dramatically, and there are significant geographic disparities, and rural communities, to sum up, have just been harder hit in terms of the opioid crisis. There's also some pretty profound ethnic and racial disparities in terms of the opioid crisis that we're starting to see more attention drawn to. So here's a couple of statistics to show you a few of the disparities that we found. So a recent study, Mason et al. 2022, looked at death rates among those 55 and older, overdose death rates per 100,000. And the total rate was just over 10, so 10 per 100,000. But among non-Latino African-American males, the rate was 4 times as much, 40. The map is from another study that looked at urban-rural disparities. And in North Carolina, our rural rate's higher than the urban rate, but it looks like where you live, Illinois, urban's higher than rural. The American Farm Bureau has done a lot of research on opioid use disorder because farm communities have been so hard hit with the opioid crisis. And so they got very interested in this, and the sources are in my reference. But they found that only about 34% of rural Americans reported that they could access substance use disorder care, while an overwhelming majority of rural Americans, and particularly farmers, reported that they had been impacted by the opioid crisis. We know that treatment access is a profound problem in rural areas. A Pew study in 2019 found that about 30% of rural Americans lived in a county without a waivered provider. And by that, I mean a buprenorphine waiver provider, I'm going to talk about in a few minutes, compared to only about 2% of of urban dwellers. I haven't always included this information in talks that I give about buprenorphine, but when I talk to my key informants who are nurse practitioners prescribing full-time in primary care settings and in mental health clinics, they tell me that things are really getting worse. And the data shows us that overdose death rates have increased in most areas of the nation. And most of this is linked to fentanyl. And the DEA has started a one pill can kill campaign, because one pill really can kill. And we find that about 4 of every 10 pills contains a lethal fentanyl dose, which is pretty frightening. And in my region, and maybe in your region, you'll have to ask around to your key informants. there's a lot of access to these fake pills. So there's these drug presses that those working in the illicit drug market have, and they take fentanyl and they press it into counterfeit pills. And here's a picture of a counterfeit oxycodone and a fake one, and I can't tell the difference. So people are buying what they think are oxycodone or Xanax, but really it's fentanyl laden, and this is contributing to overdose deaths. And what's even more concerning about the influx of these fake pills is that when maybe a few years ago, a person would need to crush and inject a medication in order to achieve a high, they would have to go over that threshold of crushing and injecting. Now folks are taking pills. And so it kind of reduces some of the barriers that might keep them from making those choices. And it's contributed to our crisis accelerating. So why are things worse in rural communities? Well, scholars are starting to look into this and trying to get a little beyond some of the more obvious reasons why. Some of it is geographic isolation and social isolation in our rural communities, which of course was exacerbated with the pandemic. Some of it is insufficient treatment access for substance use disorders and insufficient treatment access for mental health disorders that often coexist with substance use disorders. So just a lack of treatment access. Less law enforcement in the areas is one of Gregory et al.'s comments about the crisis, that there's fewer police and folks to regulate the illicit drug market. That because of the rural communities, there's a greater ability to manufacture illicit drugs. There was a recent or interesting study many years ago that looked at mountain communities in my region, and it argued that some of the meth industry had very sort of organically flowed from the moonshining and illicit alcohol industry, that it was part of kind of the culture to create these substances that was outside of something legal. Lower income, of course, plays a role. Other substance use disorders, so opioid use disorder, alcohol use disorder, disorders involving benzodiazepines, and then just concurrent health disparities that contribute to why the opioid crisis has hit our rural communities so hard. This shows overdose death rates in the United States, a percent change from June 20 to June 2021. Nationally, the increase was about 18.2%. Where I live, North Carolina, it was 27.7%. And in Illinois, per this map, it was about 22%. So again, have seen an increase in overdose death rates. Before I start talking about medications for opioid use disorder, I have to talk first about harm reduction. Harm reduction, we have a very strong harm reduction program in North Carolina. I started looking around, and it looks like you do as well in your state. But it's the idea that people using substances should be given the care, resources, and information necessary to reduce health risk associated with substance use. So it's the idea that not everyone is willing or able to cease use. And we have to meet folks where they are and help them use more safely to keep them alive until they are ready to start engaging with us about recovery. This isn't really a fringe idea anymore. It was for a while, but I think harm reduction now is pretty mainstream. So again, just another, we don't want to necessarily say that abstinence has to be the goal for everyone. There may be patients that we interact with that that's not their goal yet. And so we need to try to help them use safely if they're going to use. So what are some key harm reduction programs? Needle exchange. In my community, with the influx of fentanyl and the sort of outflux, if you will, of heroin and injectable drugs, we're really concentrating more on fentanyl test strips and drug checking, because that's what folks in our community really need. We have a law in North Carolina that protects fentanyl test strips. They're not considered drug paraphernalia. I'm thinking that you must in Illinois, because I was reading about programs in Chicago with the Chicago police passing out fentanyl test strips. So that's something to look into in your community. Where do you get those, and how can you connect your patients with that resource? Or your patients' families, because this is a conversation that I have with everyone, because it might not be the patient in my room, but it might be the patient in my room's son, daughter, grandson, granddaughter, neighbor. Narcan access is huge, especially in our rural communities. We have to get folks access to naloxone, teach them how to use it, and teach them to tell folks where it is. There's a clinic in my area where it's a nurse practitioner that I work with, and they've created posters for that clinic. It's not my clinic, that read Narcan on the kitchen table. And it's a reminder to tell folks, don't just have Narcan, but have it and make sure people know where it is, so that if you do experience overdose, it can be found and your life can be saved. So how to have it, where it is, how to use it. And to really talk to our patients about avoiding concurrent use of opioids and benzodiazepines, to have those discussions. If you're going to use, here's how you can use more safely. And here's a source, Injury-Free NC. North Carolina has some great resources, and you probably have something similar in your area. So medications for opioid use disorder. Well, there are 3 FDA-approved medications for opioid use disorder: methadone, naltrexone, and buprenorphine. And of course, buprenorphine is typically combined with naloxone to prevent misuse. We have years of data on these medications, and we know that they decrease overdose death and increase chance of long-term discovery. That's just one study. There are piles of studies on the effectiveness of these medications. But fewer than 20% of folks who seek treatment actually receive it, and it's probably closer to 10%. And there's some pretty significant racial and socioeconomic access disparities in that treatment, and also geographic access disparities, that folks in our rural communities have more trouble accessing these medications for opioid use disorder. And then there's a problem that more and more attention is being drawn to, that about 1 in 5 pharmacies don't stock buprenorphine. This has been a problem in my region. Some of it is supply, but some of it is pharmacies choosing not to have this medication, even though it's a treatment medication, based on stigma, that they don't want people coming into their communities to get buprenorphine, even though buprenorphine is also indicated for use in treating pain. That's another use for buprenorphine. So just a few things about each of these medications before I talk more in depth about buprenorphine and how to prescribe, how to become eligible first to prescribe buprenorphine. But methadone certainly has been around for many, many years. People are very familiar with it. It's a Schedule II medication. It's a full agonist. You have to have a DEA license to prescribe methadone, but it can only be prescribed in opioid treatment programs, SAMHSA certified opioid treatment programs. Some of the downsides of methadone, one of them is that for at least the first 90 days, a person has to present daily for treatment. Well, this is a problem in our rural communities, where someone might have to drive an hour or 2 hours in order to reach a methadone clinic. There aren't many of them around. They're typically concentrated in urban areas. So that's a cost, particularly with the price of gas, that people have to have a car. They have to have time away from their families and work in order to go get methadone. There's also a number of significant medication interactions with methadone, and some folks are at risk for QT prolongation with methadone, and sometimes people will be actually referred to buprenorphine clinics because of QT prolongation. Then there's naltrexone, which is not a scheduled medication, Vivitrol, And it doesn't require any sort of specialized license. Anyone who can prescribe medications can prescribe naltrexone. There are some pretty significant downsides to naltrexone. First, a person has to have experienced full detoxification, usually 7 to 9 days before they can be started on naltrexone. So there's not a whole lot more to say about that. That is a huge barrier in and of itself. Often folks will be started on naltrexone on inpatient settings where they were able to experience that detoxification with some pharmacological support in an inpatient setting. But another issue with naltrexone is that there's a very high overdose risk if folks relapse. So the way naltrexone works, people who relapse may go back to using opioids and try to use them at the same dose that they used before, or even if they use it at a lower dose, their body can't handle it anymore and they risk overdosing. And unfortunately, in my research, interviewing nurse practitioners who prescribe these medications, I had several tell me stories of patients who had passed away after being on naltrexone, going off the medication, whether they went off it themselves or whether they came in and a benzodiazepine was found in their urine and a prescriber decided no longer to prescribe them naltrexone, and they went and used again and died. So now there are other people. I have a psych mental health nurse practitioner colleague that I work with, and she's had a lot of good experience with naltrexone, particularly with alcohol use disorder, which is also used for, but those are some of the issues with naltrexone. Then, of course, there's buprenorphine, which buprenorphine is a partial agonist. It's a Schedule III medication, and it requires this DEAX. Now, buprenorphine is sort of the medication recommended for primary care settings. It's combined with naloxone that prevents individuals from crushing and injecting the medication. The naloxone isn't, when it's taken orally, the naloxone is not, the uptake of it is not such that it would make the buprenorphine not work, but it is if it's crushed and injected. And there's not many safety concerns with buprenorphine. So it's a very safe drug. People don't have to present every day to a treatment center to receive it. And so it's been recommended for rural areas. I keep looking to see how I'm doing on time. So this is where things get confusing for some folks. So buprenorphine is, like I said, a Schedule III medication, and you have to apply for a DEAX waiver in order to prescribe it. And sometimes it's called a DATA waiver, a DATA 2000 waiver, and I'll tell you what DATA means in a few minutes. But an X waiver is just your DEA license with the first letter replaced with an X. So I gave an example there. In order to apply for a DEAX waiver, number one, you have to hold already a DEA registration. So you have to be eligible to get one in your state. And there are some states where nurse practitioners can't hold a DEA registration, not many, but physicians, and I don't know, I am not well versed on physician assistant regulation. You have to complete training. There's an asterisk there because I'm going to talk about an alternative NOI, which is 8 hours for physicians and 24 hours for other prescribers. Then you have to submit a notice of intent to SAMHSA, and I gave you the link in my toolkit. If you are an APP, a nurse practitioner or physician assistant, you have to meet the collaborating supervising physician requirements of your state. It takes about 45 days to get a DEAX waiver, and you can request expedited approval and maybe make a case if you've found yourself, maybe you're in a community where the only X waiver provider has left and you're stepping up to fill this need to help people stay in treatment. You could write and ask for expedited approval. So something very exciting happened last April. The federal government changed the rules around the Controlled Substances Act very slightly in response to some barriers to buprenorphine treatment. And what they did was they eliminated that training requirement. Remember, I said physicians had to do 8 hours of training and nurse practitioners and physician assistants had to do 24 hours of training. Well, they got rid of that because people perceived it as a barrier. And in my research, many of the nurse practitioners that I interviewed asked questions like, if I don't have to get specialized education to prescribe an opioid, why do I have to get specialized treatment to prescribe buprenorphine for opioid use disorder treatment? That said, I'll go ahead and put this caveat there now. I think this training is incredibly valuable, and I think everyone should do it. I think it's great that that barrier's been removed because maybe some folks have, maybe you did a lot of rotations in your residency in substance use disorder, or maybe you had some kind of other training, but you can really learn a lot from this training. And I tell the nurse practitioners that I work with, even if you don't do the 24 hours, please do the first 8 because I think it's very valuable. This alternative NOI also eliminates the requirement to, quote, certify capacity to provide counseling and ancillary services. I'm going to talk more about that in a few minutes. If you get an alternative NOI, you can only treat up to 30 patients. And any time that you spend treating patients under an alternative NOI does not qualify you for a higher patient limit. You'll find out what that means in a minute. You must meet this, I forgot to change this, you must meet the collaborating physician requirements of your state if you are an APP. So this is a chart I made to help folks understand the different waiver types. So there are 4 different waiver types. First is the 30E, which is the one that I just talked about. It's the exempt one. You don't have to complete the training. You can only treat up to 30 patients. Now, there was some confusion earlier when the rules were changed and people thought, oh, I can treat 30 patients without a DEA-X. No, you still have to apply for a DEA-X. You just don't have to do the training and you don't have to attest that you have access to counseling and other ancillary services. Again, the DEA was doing research on this. There was an escalating opioid crisis, especially with the pandemic. They saw this as 2 barriers that they could move. So that's the 30E. Then there's the 30 patient waiver, which you can, and I should add that there are some differences for a physician who's board certified in addiction medicine. That's not my audience here. I'm thinking more of folks who are working in primary care settings. So 30 patient waiver, you have to complete the training and attest to counseling and other ancillary services. Okay, now out the door, you can apply for a 100 patient waiver in your first year out. It used to be that you had to work in this 30 patient waiver and then you could apply, but now you can apply for a 100 patient waiver from the get-go, as we say here in the South. If you work or treat patients in a qualified practice setting, and that's one that provides off hour coverage, has access to case management, has an EHR, is registered for the PDMP, accepts third-party payments. Those are what you have to do. You still have to complete that training and attest to counseling and ancillary services. You can apply then after 1 year at a 100 patient waiver, you can apply to treat up to 275 patients. But again, you have to meet those qualified practice setting criteria. For nurse practitioners and physician assistants who may be in the audience, per federal policy, physicians who are supervising waivered advanced practice providers must be eligible to apply for a waiver, but don't necessarily have to have a waiver. So this means that you couldn't work with a physician who had, for whatever reason, lost their DEA privileges because they wouldn't be eligible to prescribe for a DEA-X license if they didn't have a DEA waiver. So that makes sense. However, state law overrides. So in North Carolina, as a nurse practitioner, I am required to work in a collaborative practice agreement with a supervising physician. And per the North Carolina Board of Nursing, I have to work with a physician who also has a DEA-X. Now, some people get around that by having 2 collaborating physicians, one without an X and one with an X, to help manage their buprenorphine prescribing. And we also have to include it in our collaborative practice agreement, which is the agreement that we write that discusses what we can do, how we contact our collaborating physician, and what medications that we can prescribe. But look in your state for pilot programs. There is a pilot program in North Carolina funded by the Governor's Institute, which is an institute for substance use disorder, and in response to the crisis in our state, that allows nurse practitioners and physicians assistants as part of this special program to prescribe buprenorphine without having an X-waivered supervising MD. I looked around, I didn't see anything like that in your state, but you know your state better than I do. Look around for these pilot programs, because if you're an APP and you can't identify a X-waivered physician to work with, maybe you can find one of these programs. So how do I get the training? First question, you can go back to this, the 8-hour, 24-hour training. There are many places you can get it. I gave you some here. The training doesn't expire. So that's also why I tell folks, even if you want to just apply for the 30E, please do the 8 hours and keep it. Just keep the certificate, because when you go on and want to prescribe with a 30 patient waiver, 100 patient waiver, you can just go back and use that. So whose data waivered? Well, not many folks. This data is a little bit old, but as of 2019, we had less than 6% of physicians, about 3% of nurse practitioners, and just under 2% of physician assistants. The data is not publicly available. That's why I can't update it. You have to purchase it, and it's outside of my research budget. There are publicly available lists, but providers can opt out of those lists so they don't tell us the whole numbers. But Spets et al. Had the list that they could purchase, and so this was a very accurate number as of 2019. But I will tell you that this number doesn't tell us the whole story, because studies tell us that only about half of waivered prescribers have ever prescribed. So you can cut that number in half right now, because someone might have an X, but half of them have never prescribed buprenorphine for opioid use disorder. Then after that, we cut the number even further, because many prescribers prescribe to far fewer patients than their waiver allows them to. So why? So as I mentioned, I've been working on barriers and facilitators to nurse practitioner prescribing. But what I've found is that the barriers and facilitators for nurse practitioners very closely mirror the barriers and facilitators for physicians. And there's also been very little work done on barriers and facilitators for physician assistants. So that's an area of research if anyone's interested. So some of the barriers are regulation, perceived DEA intrusion, counseling requirements, and stigma is a huge one. So many of my respondents reported diversion as a barrier. They were concerned that people were going to come in and divert this medication. What's really sad about that is studies tell us that most diverted buprenorphine is for treatment. Folks are buying diverted buprenorphine to treat withdrawal symptoms. It's more expensive than medications they could use to achieve a high. So they're buying it to stave off being dope sick, to the point that in the physician literature and in my studies, my providers told me patients come and they know their starting dose. Most patients who present for treatment are not naive to buprenorphine. They've used it on the street, they've bought it, it worked for them to the point that, again, they will know the dose. Now, a caveat to that is that sometimes they will come to you and tell you, I'm allergic to buprenorphine, because they took it on the street and they weren't far enough into withdrawal and they experienced precipitated withdrawal. So they'll tell you they're allergic, but really they probably experienced precipitated withdrawal. Another major problem is perceived counseling requirements. So people perceive that they have to have access to these very robust substance use disorder counseling programs, but studies have just told us that that's not necessarily the case. Weiss et al. Is an old study, but it's one that's consistently referred to in the literature. It was a randomized control trial with standard medical management with one group who was on buprenorphine and opioid dependence counseling with the other group. And they found that it was not inferior to opioid dependence counseling. So motivational interview, these kind of counselings are things that you can do. Any provider has some knowledge, hopefully, of motivational interviewing. And if you don't, it's in that first 8-hour module. And also programs are more and more using peer recovery groups. And I included in the references a study about peer recovery groups that you can look to. And some places are alternating provider support with peer recovery support. Stigmatizing language. Stigma is overarchingly the biggest barrier. I've found this in my study with nurse practitioners, and it reflects literature on physician prescribing, on pharmacy, and just the bigger community. So we've really been working hard with our students to help our nurse practitioner students move away from this stigmatizing language. Person-centered language, person with substance use disorder, individual experiencing substance use disorder, and getting away from these words like abuse, addiction, addict, junkie, dirty urine, opioid replacement therapy. We have to move away from those because those words are so powerful and they reflect how we think about addiction. And some people even argue that stigmatizing language and using it contributes to burnout because it sets you up for a negative adversarial relationship with your patient. So we've been working with this in my college because we found that some of us, not even thinking, were using language like dirty urine. Induction. Dr. Michael Fingerhood, who is the co-author literally of the book on addiction medicine, the Handbook of Addiction Medicine, says, stop calling it buprenorphine induction. And I think that's so smart and so wise. And he has done such great work on reaching communities and treating opioid use disorder with buprenorphine. And he says that this language of induction, sorry, there's supposed to be another paragraph mark on the other side of that 2019, but that work of reduction, that language of induction sort of mystifies buprenorphine and scares people away from it a little bit, both providers and patients. And he makes the argument in a podcast that I posted for you. It's a great podcast. I would really recommend listening to it. He says it's easier to start someone on buprenorphine than on insulin. And we don't call it insulin induction. So stop calling it buprenorphine induction. Just call it initiation or starting buprenorphine. Stigmatizing language. Another one is medication-assisted therapy. And I have been working so hard to get this out of the vocabulary in our college. Really just over the past few months, a colleague and I have been working on this because this language of MAT, and Wally 2019 I posted has another great podcast where he talks so persuasively and powerfully about why we need to move away from that language. It suggests that medication plays a supporting role and that it is not the medication that is the treatment. And he says we've really got to get into a medication first mindset, that first we get folks on medication, we reduce the barriers to those 3 FDA approved medications for opioid use disorder. And then we can start adding some of the other elements that may help them succeed and stay in recovery long-term, like counseling and peer support. But he says that we really need to rethink addiction, change the way we think about it. The old model was we have to make the patient work for the therapy. But the new model is we make the therapy work for the patient. And so that's why we're calling it MODE now, medications for opioid use disorder, and not medication assisted therapy, and certainly not opioid substitution therapy. So I just tell my students and my colleagues, if you wouldn't say it for another disease process, don't say it for this one. So don't say, if you wouldn't say your patient who comes in with glucose in their urine has a dirty urine, don't say it for a patient who comes in and you find a substance in their urine, because it doesn't help. So what are some of the facilitators that I've found in my research? Mentorship, experiential learning, flexibility, boundaries, providing resources, and reward. So what I found, and this is consistent in the physician literature, is that folks who had a prescribing mentor did much better with their prescribing. And one of my respondents said, in getting to see how his practice worked, I sort of got to learn who was a good candidate and who might not be. And another one said, I needed someone I could call in real time. There is a provider clinical support, PCSS, it's supposed to be PCSS, not PCCS, mentor program. I linked it in the toolkit, but many providers, according to a study by Hun and Dunn in 2017, were unaware of this program, but it's a great program. And if you want to prescribe, reach out to them. They will help set you up with a mentor. Patient support. Remember, I mentioned that a perceived barrier was that people needed access to a substance use therapist, substance use group therapy. But what my respondents told me is what they really needed to do was hone their motivational interviewing skills. And I won't read this quote in the interest of time, but it's from a family nurse practitioner in my study who was prescribing. She had a 100-patient waiver. She was in such a rural area that her clinic was literally in the middle of a cornfield. And she was using motivational interviewing, and she had done a lot of research on the work and was actually in a doctoral program at another university, and had found that there was no support, that they have to necessarily go to addiction specialist. Some other things that I learned in my research is that contracts are very important, drug screening, but using a non-punitive approach. Dr. Michael Fingerhood talks a lot in his work about asking patients before you drug screen them. So if a patient tells me, yeah, I slipped up and I used cocaine last week or whatever, why in the world would you drug test them? They're going to test positive. Say to them, why did you slip? What's going on? How can we help you? And maybe bring them in again. So I think with these patients, we need to anticipate that relapse is going to be part of the recovery process and adopt a non-punitive approach. Because if we adopt a punitive approach, we risk them dying. The stakes are so high. And so these groups that take a punitive approach kick somebody out at the first the first sign of relapse, they risk that patient going back on the street and using and dying. Another thing that I've learned in my research is to create a relationship with the pharmacy. So there's still a lot of stigma among the pharmacy community. There's studies about it. Find pharmacies in your area that, number one, stock the medication, and number two, are going to treat the patients that you send them respectfully. And that's a tall order, but if you can find that resource for your patients, it will help them stay in recovery. Another strategy is to give very short-term prescriptions. So one provider that I was working with had started off by writing patients prescriptions, patients who were stable on the therapy, prescriptions for 15 days, 30 days. But they would go to the pharmacy and not be able to afford to fill all of it. But then the pharmacy sometimes would forget, or something would happen, and they would go back to fill the rest of that prescription, and they wouldn't be allowed, and she would get another call. So she found that asking patients, okay, how much can you afford to buy at a time, and writing them a prescription for that amount helped the patient stay with the medication and prevented additional calls to her office. Another thing I learned from my respondents was that many of them would prescribe remotely to patients that were stable, because patients would become stable in the program and go out of town for work. So I'll leave this for you. This is a quote about reward, but I'm running out of time. I was afraid I might. So some of it, can I go over a few minutes, or do I need to hard stop at 1 hour?
No, I think you can go over.
I can go over? Okay, then I'll slow down a little bit. So let me go back actually and read this then, because I think this is so powerful. This person was prescribing in a rural area to many, many patients. She talked in another quote that I have about, she had whole families in her buprenorphine program. So she would have fathers, children that came with their parents, and they were all on buprenorphine. They had all been addicted to opioids. So she says, so there's a lot of attention to be paid and accommodations to be made. But in the final analysis, it's so worth it. You know, when they get back to working, they get their kids back, they get their relationships, they are getting back to life. And you can tell too. I don't know if you've seen the difference when they are addicted and when they are clean, but when they come back to the appointments, it's like a different person. The faces have filled out. You know, a lot of them have bad dental issues. I mean, it's like a complete change once they are stable in the program. They put perfume on. They are like a different person. A lot of these guys, they come in scrawny and just looking horrible for a few appointments. And then when they come back, now that they've been in the program 6 or 8 months, I don't see them for a month, and they come in and I'm totally surprised at how well they look. They are eating better. They are happier. There is not that stress. They are on the right medication. So it's a very gratifying thing to do. So I use this as an example as my respondents tell me this is incredibly rewarding work. They feel that they're making a difference in their communities. This is also supported in the physician literature. They're not experiencing a lot of burnout because they're making a difference and they're seeing changes. So a few prescribing tips. It is hours and hours to talk about how to prescribe buprenorphine. And you should take that 8-hour class so that you can learn how to do it. But just here's a list of the different products approved for AUD treatment to help you. Of course, new ones are always coming out. Here's the training again, because I truly feel that you should at least do the 8 hours. Some safety concerns. Right now, Buprenorphine-Naloxone is not approved for pregnancy, just buprenorphine, but I think that those guidelines are probably going to change. So if you decide to prescribe, pay really close attention to that, because I think we may find that changes shortly. We used to be told not to prescribe buprenorphine to anyone who tested positive for benzodiazepines. The FDA has changed that because the stakes are so high. If we would, of course, never start a patient on a benzodiazepine and buprenorphine, but if a patient is using a benzodiazepine or using them recreationally, that's not necessarily a reason to stop their Suboxone or their buprenorphine, because they may go and take another stronger medication and experience overdose. So that's something to consider. Some tips that aren't as obvious in the training: talk to your patients about their experience with buprenorphine. Again, because of the diversion, many of the patients who present to you will already have taken the medication. They may well know their dose. Check your controlled substances reporting system prior to prescribing. That's very important. In North Carolina, we have to. Motivational interviewing, have your patients set their goals. Michael Fingerhood tells his patient, my definition of recovery is today is better than yesterday. But ask your patient what their definition is and what their goals are. You can have folks start it at home or in the office. And in my toolkit, I have a patient-driven app. If your patient does have a smartphone and does have access to enough enough internet access that they can use an app, you could suggest that to them. And you have to use a withdrawal measurement tool. The COWS and the SOWS are the two most widely used. They're easy to find on the internet. Typically, you want to go by a COWS of 6 to 10, not necessarily a specific time. And again, my respondents told me patients often know already when they need to start the medication. They've experienced withdrawal before, and so they have an idea of how long they need to be in withdrawal. If they've had precipitated withdrawal before, or if you're concerned that they're at high risk for that, you may want them to wait a little bit longer. This is covered really, really well in the training. But folks are telling me with fentanyl, because fentanyl is so lipophilic, that often you really need to wait a little longer so that your patient doesn't experience precipitated withdrawal. You can read over some of those. You may have to prescribe some adjuvant therapies to help your patients with nausea. I want to talk just quickly about some of the toolkit things that I've included. Here's some practice guidelines. The second one tells you how to get an X waiver. The buprenorphine quick start guide is great. This fourth is the Yale School of Medicine faculty created this Bup Home Initiation app, which is a great resource for your patients. Of course, go to the provider's clinical support system. They have great blogs on prescribing, a mentorship program, so many resources. Here's some of you might have been thinking, but wait a minute, sometimes you can prescribe or provide buprenorphine without a DEA-X, particularly in inpatient settings. And there's a link that tells you a little bit more about how you can do that. And of course, folks can prescribe buprenorphine for pain. There are pain patches for buprenorphine without an X waiver. You have to have an X waiver to prescribe buprenorphine for opioid use disorder. One Pill Can Kill campaign. I know a lot of folks who are printing these campaign sheets and putting them in their office to start that conversation. There's linked to the COWS and the SOWS. NC Drug Users Guide, I don't like the title of it, but that's a great resource that we share with patients that we think need it. In our state, it's county by county, and it tells patients where needle exchange programs are, where food pantries are, where treatment for hepatitis access is. There's some guidelines for pregnant women, guidelines for transitioning patients from methadone to buprenorphine, and then a resource on racial bias in the U.S. Opioid epidemic. So if there's time, does anyone have any questions for me?
We actually have one question.
Okay.
The question is, I am a physician practicing in a rural southern area. I am not associated with the medical school. She just found this training from searching. I feel like my training had a lot of bias against this patient population. Where should I start with improving my motivational interviewing skills? I worry that I picked up a lot of bad habits in training that I want to correct so I can help patients better.
Well, first of all, thank you for this question. And I relate to it because I think in my training, in most healthcare provider training, we saw some of that bias. I think that some of those resources I provided, the first thing I would do if I were you is go to Michael Fingerhood's lecture or podcast on curbsiders and listen to it. And he talks about motivational interviewing and how to open the conversation with your patients. Do the 8-hour training, or just start the 8-hour training and skip to the motivational interviewing section. Look at the stigmatizing language, because there are so many stigmatizing stigmatizing language that we use that we don't even think about. I said clean urine for years until someone said to me, stop saying that. And then I thought about it and I changed the way that I think about it. So I think some of those resources will help you. And PCCS also has a motivational interviewing podcast. Because I live in a rural area, it's an hour. Basically, it takes an hour for me to get anywhere. And I live in the sticks. I told someone that. And I listen to podcasts everywhere I go. And I go to PCCS and some of the other addiction medicine sources and find things to listen to. So thank you for your question. And my email is on the list. If I can share my insights that I've learned from studying this with anyone, I'd love to. Thank you so much for having me.
Dr. Spate, thank you. This was absolutely wonderful.
Thank you.
I'd also like to mention that the SIU School of Medicine Center for Rural Health, where we work, has received funding from DHS Super using the Cannabis Act funds to offer stipends to providers in Illinois who become ex-waivered. And so this has been the third year that we've had this funding. And Kristen Carricker, I put her contact information in the chat. She's the one who is organizing this program. And there are stipends also for people who begin to implement MAR in their clinic, as well as to facilities that begin to implement a MAR program. So again, her contact information is in the chat, and this program is going to be going on for another year. I think it's going to be ongoing for a while. So thank you for joining us, everyone. And let's see, we have this final slide here. You'll receive an email to a link to an evaluation, and you'll also be able to download your certificate once you do the evaluation. So thank you so much, everyone, and thank you, Dr. Spate.
Thank you. Bye-bye.
Bye-bye.